Welcome to the next episode in the Bruker Microbiology and Infection Diagnostics podcast series, where we will be discussing how Cedars-Sinai Medical Center, a non-profit hospital and medical research institution in Los Angeles, is using Bruker's MALDI-TOF and IR Biotyper to drive new initiatives for outbreak surveillance, support routine microbial analysis, and significantly improve clinical response times. From the Department of Pathology and Laboratory Medicine at Cedars-Sinai, we will be speaking with Dr. Margie Morgan, Medical Director of Clinical Microbiology, and Dr. Deisy Contreras, Assistant Director of Clinical Microbiology. How has microbiology developed, and why have new analytical techniques been needed?
We were only capable of identifying certain organisms that were capable of being identified by the use of these very basic biochemicals. And as things move forward, it did improve, yes. By the 1980s, we were into automated systems, but still things were very, very basic. And so that's why as we moved forward and we started seeing the changing spectrum of things with like the creation of MALDI-TOF, why it's just such a magic to me. I don't need to overstate it, but from going from glass tubes with biochemicals into a spectroscopy method that can identify organisms in 20 to 30 seconds, that's like magic to me. And so I think maybe with my history, maybe I can appreciate things like this, maybe just a little bit more than someone who just started in microbiology 10 years ago when these systems were in operation. And so I think that's my background, and that's why all of these new creations, such as the MALDI-TOF, the IR Biotyper, and things, seem kind of amazing to me, because we are able to identify wonderful and weird organisms very quickly, those that we barely knew existed 50 years ago. And so I am forever grateful and forever amazed at this new technology.
What is the advantage from a clinical point of view?
The ability to actually have the power and capacity to do microbial identification in real time is amazing, right? Obviously, the limitation there is actually growing the organism and then identifying and being on the database. But the database is very expansive, that it has allowed us to identify not so common, right? We identify the most critical, common, clinically significant organisms, but also we're identifying more of these, quiet, less well-known, and it has been fun trying to figure out clinically the significance and how we go about reporting them to the physician, right? So yes, it has revolutionized the way we identify microbials and pathogens in the laboratory, and to its benefit, it has a fast turnaround time, high accuracy. It's taken time to figure out on how to relay that information to the clinical team where it makes sense to them, and then be available to them where we can actually, consult with them and work with the clinical side and see, does this make sense? Is this really a pathogen? Is it normal flora? So yes, it's created high accuracy in identification, but it also, it has allowed us to rethink how we convey this information to the clinical side as well.
Absolutely agree with what she's saying. And as also to see organisms that probably have always been out there in the environment infecting people, but we misidentified them most likely, or we called them a diphtheroid or something that was non-committal because we really didn't know what it was. I think one of the things that has shocked me the most is how much Corynebacterium diphtheria that we're seeing in wound cultures. I'm sure prior to MALDI, we were probably calling them just diphtheroids and thinking it was skin contamination. I'm sorry, that's a horrible confession to make, but that's how MALDI-TOF has really assisted us in identification of things that we didn't do very well in the past that had great significance. We can also do this very cost efficiently. In the old days, when I was doing things in the 80s and such, to identify a difficult organism, yes, it might take 5 days with multiple biochemicals, but a lot of time and money was spent. in identification of these organisms. MALDI-TOF not only makes it easier to identify, but less expensive. And so as a director, the expense is very, very important these days, and being able to do things in an economical way. So it's just kind of a win-win for us, I believe, in the laboratory using an instrument like MALDI-TOF.
How have you gone about developing the appropriate workflows? Do you have any specific examples on the MALDI Biotyper?
Yeah, I'll start with Candida auris because that has really become a very, very important organism in our environment. And I think perhaps every medical center has had a different experience with Candida auris, but we have been seeing a great deal in our medical center. Of course, I think everybody knows the pathogenicity of Candida auris, and that it's very difficult organism in a hospital environment, because not only can it cause patient infection, but it's very capable of spreading in the environment. So you have to be very cautious. You have to, we believe, develop a very good technique to screen patients incoming into your medical center, so you know who is colonized with Candida auris or not, so you can provide proper isolation for these patients to prevent spread. Initially, when Candida auris was found to be such a significant pathogen, it was recognized that a lot of the biochemical identification systems were not adequate for the identification of Candida auris. We were very pleased and very fortunate to have MALDI-TOF long-term operational in our laboratory at that time, and MALDI-TOF provided a very definitive identification of Candida auris. So we could supply good and correct identification of all of our yeast species, including auris, from the use of the MALDI-TOF. So we could be on guard very quickly if we had a Candida auris ongoing infection. The other thing that we do, and we think is very, very important, is we work very closely with our infection control and stewardship team. And so we developed very early on a method to do PCR for surveillance testing for our patients coming into the hospital, particularly for those from long-term care facilities and nursing homes, where we're seeing most of our infections. MALDI-TOF was very, very important in us being able to find these patients and know who exactly had Candida auris, so we could have proper isolation, do proper susceptibility testing, and then do proper strain typing to see what we really had in our hospital community and how we could relate that to the community of Los Angeles.
How did the MALDI Biotyper and IR Biotyper help during the COVID pandemic?
We have stakeholders at the hospital, epidemiologists, infection control, our ID physicians. It was a good collaboration. We've been seeing Candida auris appearing in the hospital, and they want to do something about it. So I was brand new to the team. I was like, I love challenges. Let's go. Let's do it. Let's take this challenge on. We can collaborative work together, with other stakeholders. And you know what? Microbiology steps up to the challenge, and we were able to develop what we refer to as a two-step surveillance program. To first detect patients based on the established criteria that was developed from this group, right? And identify patients that were colonized with this multi-drug resistant organism, like Dr. Morgan had explained. Then we wanted to utilize this wonderful platform that I was really excited to explore, right? Not knowing a lot about it and not knowing limitations. And I think that's a very good thing. If you don't know the limitations of something, you're willing to push the envelope all the way to the end. And I think that's what allowed me to really push its potential. So we utilized the IR Biotyper to do some epidemiological work, right? So like I said, we identified patients coming in from skilled nursing facilities, long-term care hospitals, the sickest of the sick, the most vulnerable patients. And they all get screened for Candida auris. So once we identify any positive PCR specimens that have a cycle threshold of less than 30, which makes it easier for us to recover the organism and culture, then they get stored for further strain typing analysis by the IR Biotyper, right? So we keep saying IR Biotyper, IR Biotyper. What is the IR Biotyper, and what technology does that use, right? It's an infrared based typing system, which uses spectroscopy to analyze the molecular vibrations caused by the absorption of infrared light. That got me, right? I was like, whoa, okay, that sounds really cool. Let me learn more about it. So it actually takes different chemical structures within the microbial pathogen itself, right? Within the pathogen itself. And it uses different vibrations within the spectra, right? A carboxyl group in fatty acids, it's going to be absorbed differently from lipids versus proteins versus polysaccharides, right? So then it gathers all these vibrations and all these data, and it actually creates a molecular fingerprint that is used to classify these organisms, right? How cool is that? A molecular fingerprint, which is awesome.
Did you consider any other methods?
We had used it prior for some other reasons, but until we started thinking about it being used for Candida auris, what was our alternative going to be? Well, it would have been sequencing. So I just want to bring the point that this provided us a much faster, more cost-efficient, reasonable option with an instrument that we already had in our laboratory that we had used for past strain typing work. And we did not have to go to the very, very expensive sequencing methods, which we were not capable of doing. So this was really a very good alternative to provide us with the information that we needed without spending all the money and resources for sequencing.
And given the user-friendly post-analysis that the software actually includes, right? It does multivariate exploratory analysis that's performed by the IR Biotyper client software within the platform itself. So given all of these factors that we have to optimize, we were able to take a subset of the actual positive Candida auris isolates that were found within our patient population, right? We were able to distinguish and differentiate among different clinically significant Candida yeast organisms. And then when we closely looked at our Candida auris specifically, we found that they were clustering. So doing this in real time allowed us to not only identify people that were colonized with Candida auris, but also gave us the ability to add that extra layer of information for epidemiology and infection control that, allows us to just trend monitor. Is there a shift within our population?
Yeah.
We create some type of database that allows us to maybe go back and do some further analysis. So I found that really neat.
Can you track Candida auris outside of Cedars-Sinai Medical Center?
From looking at the data, we could also kind of track back how things were going on with the nursing homes and long-term care facilities within LA, and that they all had this one clad, and kind of the movement of how our Candida aurises were moving around Los Angeles County. So it provided very good, just interesting information about the organism itself. And so we really felt that we were ahead of the game, shall we say. This problem is not going away. In fact, if anything, it might be getting a bit worse. Candida auris seems to have taken hold in the Los Angeles County area, and we're continuing to certainly make good use of this algorithm that we created with PCR screening for surveillance and tracking these patients, because we are still seeing a significant number of patients colonized with Candida auris.
How straightforward would it be for another group to duplicate what you've done and bring this technology into their own lab?
Well, right off the bat, I think with any new procedure, any new test, anything new that you're bringing onto the lab, there's a learning curve that goes along with it, right? So something that might work with in my hands, might take a little bit more optimization across another lab. But the support that Bruker has provided us with is immense. The use and the utility of the Biotyper Kit is straightforward. The only thing that one has to optimize is, the temperature. Humidity actually does affect. So the humidity in my lab might be totally different from the humidity in another lab. Sure. But things like that we can't technically control, those are the most difficult aspects that I see affecting the data. But soundly speaking, technically, everything is pretty straightforward. It's fairly easy to perform. Our CLSs have welcomed it. They're very well trained. They were not hesitant. The vendor provides you with the skeleton, but it's up to you to optimize that and make it work for your laboratory and your workflow.
It's really a fairly user-friendly system that does not require a great deal of skill, particularly for the bacterial isolates that have been well characterized over the years, and there's many protocols available. And that's what we started with. And I agree with what Deisy is saying. It's user-friendly, and Bruker provides a great deal of support. And so it's not a difficult system to bring into your laboratory compared to doing sequencing.
How important is the development of the database behind the MALDI-Biotyper and the IR Biotyper?
I think I can comment for the MALDI-TOF that it is very, very important. It also keeps taxonomic updates as well. And so it is far beyond the biochemical systems offered by automated systems. And it provides a very good updated taxonomy and identification system for our laboratory. And I think it has been a great assistance with providing proper identification and proper taxonomic classification.
From the actual IR Biotyper perspective is just, utilizing that AI feature in terms of classifying our patient population, the strains that we're identifying, right? Not only that it is important within our hospital setting, but it's also important to see what's going on in the community, right? Right now, Los Angeles area, we're noticing that Clade 3, that African lineage actually is endemic to the Los Angeles area, and other institutions have also characterized their patient Canada R as isolates through whole genome sequencing and have been finding the same results that we found through the IR Biotyper. So it's not just within the hospital setting creating a database of our patient population, but our patients go through the surrounding hospitals. We get transferred, they get transferred to us from local skilled nursing facilities, long-term care hospitals. So we also know what's going around there. So it's important and critical to do these types of studies.